There we go. Okay, so my goal for this touch point presentation session for you is that we make sure that your chart audit criteria look good. It's very common that you have to repeat it several times to get the data that you need to have a good baseline. But we just want to make sure that your chart audit's looking good, that you're off to a good start. We're going to make sure that your patient and team surveys look legit, and then have a little bit of Q&A, okay? This could last anywhere between an hour and a half. The last session with 4 people was an hour, but they also didn't have a ton of questions. So we can take as much time or as little time as you need, okay? So can I have a volunteer timekeeper just to give a heads up if someone's at 4 minutes, say 4 minutes, and then when they're at 5, you can just type in the chat box like 5 minutes, just so that I know that they've hit 5 minutes. That way I can pay attention to your presentation. Is there someone who likes to be anal about time? All right, the German.
Yeah, right.
Very good. Okay, sounds perfect. And then what we'll do is we'll just go down the line. Well, I can time you because you'll go first. Okay, so let me set up my little timer here, but then we'll time everybody else. So, okay. And then we'll save questions and comments for after everyone's done, because what usually happens is there's some themes that are happening in everyone's or in a few people's, and then we'll kind of give some feedback that way, okay? All right, so Sandra, go ahead and, so what you're gonna do is hover on your left corner of your screen and you'll see a green computer screen with a white arrow in it. Do you see that?
Mm-hmm.
That's your screen share. So the touchpoint ones can be a little glitchy because everyone's still learning all this technology. So we expect that. So you can go click on that green app. And then if you have your touchpoint pulled up or your presentation pulled up, then you can select share application window. And then it'll just pull up the actual application versus, yeah. So then you want to do slideshow. You want to select the slideshow. Yeah, beautiful. That looks great. Okay, so whenever you're ready, go ahead and start.
All righty. Join me in improving Christa Spawn's breastfeeding rate. Christa Spawn is located in Corpus Christi, Texas, which is about 130 miles southeast of San Antonio. I'm a native of Germany and found love in the United States. Being in the hospital is scary. Medical lingo is thrown at you. You're trying to stay afloat with your plan of care or even what they're trying to say or what they're saying. I had my first child in the United States and I was suffering. I thought I understood a little bit of English and I wish there was a better way to communicate with me. I did not understand a word that was conveyed to me about my care, so there was really no compassion. Challenges that arise during breastfeeding are challenges that we will experience through our project. So through teamwork, open communication, and best practice guidelines, this can be a success, just like the breastfeeding journey of ups and downs. Let's see. Breastfeeding rates have been mostly decreased over time at Christa Spawn South, and the goal is to increase those rates. National data starts at 83.2% for ever breastfeeding, even if just put to the breast once, and decreases to 35.9% at 12 months. We know that breast milk can decrease illnesses such as otitis media, gastroenteritis, and necrotizing enterocolitis. Savings in only these categories can be as much as $3.6 billion. Evidence shows that using breast milk can reduce childhood obesity, and potential toolkits found are from the U.S. Preventive Task Force. Here's a snapshot of data I have thus far gathered, and some of the gaps highlighted are noted in attending antepartum breastfeeding classes. There's a huge fallout, and this can help increase breastfeeding rates. The Journal of the American Medical Association guidelines shows improved success with immediate skin-to-skin after birth, as well as the WHO emphasizes the importance on breastfeeding within the first hour, which there is a gap as well. The breastfeeding medicine protocol talks about the need for assessment throughout the hospital stay and before discharge, and the need for assessing risk factors for anticipatory problems before sending the woman home. So this is my proposed team survey. I have not yet surveyed the team. This is my proposed patient survey as well. I have not surveyed the patients yet. So my vision in the next 3 months is to increase the rate of breastfeeding at discharge to greater than 70%. Early intervention of breastfeeding will have a lasting impact on the future of self and healthcare in general. Imagine yourself being this patient that is needing compassionate help from qualified nurses. How would you achieve this? Be an influencer, not a downer, to bring quality healthcare to patients. And one interesting website I found is the United States of Breastfeeding Committee. It has actually a lot of resources on that website. And my resources.
Can you go back to your surveys? I just want to look at the questions real quick, just so I can. Okay. Yeah, let me see here. Team, you're still going to find how valuable. Okay, thanks. And then your patient?
Hang on.
Okay, thank you. All right, good. Awesome.
Thank you.
Your English is really good. How old were you when you came over?
24.
Oh my gosh.
Yeah, I get that a lot though.
Wow. Okay. All right, Lee. You're up.
Okay. Let's see. All right, can everybody see that okay?
We did. Now it looks black.
Yeah. Oh.
There you go. Then you just do the, like, maybe starts. Yeah, there you go.
Can you see every picture is okay?
No, maybe move forward a slide and see what happens.
Anything there?
No, that's really weird.
I can try sharing my entire screen rather than the application window.
Yeah, and then if we can see your screen, that's fine.
Okay, let's see. Your entire screen.
And Sandra, you'll be timekeeping, right?
Now can we see anything?
Yeah, it looks great.
Okay, awesome. Okay, so what I am interested in looking at and what I've seen a need for is psychological trauma. As you can imagine, it undergirds, well, a large part of healthcare, but in particular, a large part of mental health care. This is actually the team that would be involved in my project. This is 5 different psych nurse practitioners, 2 different therapists, and 3 different staff members. What I did want to mention here, and which will kind of be an interesting thing going forward, is these are all independent providers. So I have an interesting setup in that my team is a little bit ambiguous isn't the right word. It's kind of a different understanding of the word team. How about we put it that way? Because each person has their own business. So this is people sharing space and sharing resources and sharing staff. However, this is 7 different businesses. Obviously, I didn't put myself there. because I'm right here. So like I kind of mentioned before, I am a psych nurse practitioner. I opened my own practice back in August of last year, having moved from the community mental health area and inpatient and all the above. The name of my business is Spectra Integrative Psychiatry. And what I think trauma plays a role here in is particularly the integrative role, and remembering that it's not necessarily what we're just seeing in front of us. It's everything that's behind that. I kind of talked a little bit about this a bit earlier, but how I got here is starting in teaching and moving into the counseling and therapy field and emerging into nursing. Kind of a very something that stood out is directing me to really where I am today is when I taught high school. And as I noted there, is in rural Georgia. And really quickly figured out that there was a lot more going on in these teenagers' lives. And I wanted to play a role, I guess, more behind the scenes rather than literally standing in front of 30 of them. So the story of us, I kind of thought from the role of psych nurse practitioners or really mental health in general. You may recognize this picture, but considering all of the information that's been in the news recently about the migrant children at the border and how there are various laws and guidelines that say that we cannot comfort these children or the federal officials cannot comfort them. So thinking about the long-term psychological trauma and psychological harm that everything that's going on in our lives, not just what's in the news and what it can do to us and what it can do to our patients. So when I thought about this problem, I thought kind of large scale. I won't go through word for word here, but it goes through everything from 9/11 and the direct costs, Hurricane Katrina, and the costs that it has on our total economic system. Even looking at more personal things, such as miscarriage and not having insurance, what that can cost the individual. There are more indirect costs too, of course, kind of large scale, nationwide, local too. But just what the impact on our overall healthcare system is. And then, of course, kind of what this project is looking at are the intangible costs. So what are those traumas? What are the long-term effects? And how do we get them treatment for abuse, for neglect? For, of course, the related mental health symptoms too, everything from depression, anxiety to psychosis as well. And so really looking at it from a realm of what I've found so far in terms of toolkits, largely the VA, as you can imagine, has a large repository of information on how to assess and treat. So chart audit did complete. This works over time from the top to the bottom. And so you actually see improvements, I'd say, but remembering that these are all my patients. So these are not the patients of the other providers. So the team questionnaire is here. I had to get a little creative here because, again, understanding what team means here took some thinking, took some thought, but trying to get a sense of what we can do given the space and resources we share. Then we have the patient questionnaire. I haven't been able to implement either of these yet, but they're in the process. The conclusion here is really the vision is to appropriately screen, and I know it's a high mark, but just appropriately screen all patients, considering we work in psychiatry and mental health. So I want to screen all of these, fully assess for the symptoms, and then refer as necessary. Skipping a bit to the bottom there, you see the SBIRT model, which we typically use for substance abuse. There is a new theory that we can use that for trauma as well. So really we're looking at screening. We're looking at brief interventions we can do in psychiatry, and then referring out. Generally by that, we mean to talk therapy. You can see there some evidence-based talk therapies that likely will be included in that. But I believe that's bordering on my 5 minutes. And then my, just really quick, the PTSD information from the VA is what I found to be particularly helpful. As you can imagine, in terms of the trauma element in trauma world. So that's it.
Cool. Great. Thank you. I've been reading a lot of interesting data about the past use of psychedelics in trauma therapy. It's really interesting.
Yeah.
One day, maybe that'll be back on the list. We'll see.
I will let the VA manage that first.
Yeah.
Bit above my pay grade, but
Yeah. Okay. Let's see here. All right, Bradley. I think you're muted.
Dr. Brizzoni,
Yes.
do you want me to continue writing on the side right here or kind of blur out 4 minutes or?
I think that's fine because I'm just making note of it.
Okay.
Yeah. Yours is doing the same thing. I think for some reason with PowerPoint, they want you to share your screen and not do the application window. I haven't seen it have that
Okay,
problem.
now you can hear me, yeah?
Yeah, now we can hear you.
Okay. Sorry, I thought I had done that. Okay, so share. Okay, you can see my screen.
Yes.
Okay, hold on. I'm going to get out of this. Escape. There we go. Can you still see it if it's in full screen?
Yeah, I'm seeing it in present. There. That's good.
You can see it? Okay, good.
Yeah.
All right, perfect. Okay, so all right, so basically my project is taking a look at sitter use in an urban hospital. So this is the Queen's Medical Center. It was founded by a king and queen of Hawaii. And rumor has it that they went door to door to ask for donations to start the hospital. And you can see in the top picture what the first hospital actually looks like. And that facade is actually still a part of the hospital. Bottom picture is what it looks like today. It's obviously grown a lot. So the question is, how do we continue excellent patient safety while ensuring cost-effective care with evidence-based interventions? So one of the things that the hospital is managing is the cost related to sitter use and making sure that patients are receiving good, safe, quality care. Some of the arguments related to continued sitter use is related to safety and patient care. But the reality is that actually is not necessarily the case. So, we work with all different kinds of people in the hospital. The cost of the sitters is high and contributing to overall healthcare costs. So what can we do to kind of bring that back a little bit? So here's me. I am president of the state nursing organization here in Hawaii. That's a lei at our that I was given at our last conference. This is my family. As I mentioned before, I have several degrees. Moved to Hawaii 12 years ago. Mental health just kept on following me. I already talked about my current roles, but the reason why I wanted to be part of FNU's program is really because I felt like I could learn a thing or two about rural healthcare. The reality is that Hawaii is definitely a rural state. So the team that I'm working with are unit managers, financial folks, nurse practitioners, and a psychologist with the behavioral health unit. And these folks are caring, they're motivated, they're super smart, and it really is a diverse group of people. So I'm really excited that we're working together. So what is the problem? So as I mentioned before, sitters are driving up the cost. However, my team at the hospital was able to save the hospital about $900,000 over 1 year. However, my team is also dissolving. And so we need to figure out a sustainable way to continue these savings. So that's what this project is about, is what can we do to make sure this continues to happen with the reduction in costs, but still continued important, safe patient care. So, the safety data that we can look at is related to falls, injuries, other healthcare costs that we're going to be considering in this team. So the chart audit. So I'm still working on it. We only get about 2 to 3 sitters a day, so it's not completed. It should be done this week. But some of the biggest gaps that we see, not many units are following the policy. They move right straight to ordering a sitter without considering other excellent interventions. They're not practicing evidence-based guidelines. And oftentimes they don't have us come in to see the patient to provide our own recommendations through the behavioral health department. So definitely some things that we can work on. But one thing is for sure, at the end of this process, hopefully that is something that we'll be able to ensure that the sustainability of safety and fiscal responsibility is present. So here is the team survey. One of the more important questions, I think, actually is the last one. Do we have the right people at the table? That's definitely something that we'll continue to assess as we move forward with this project. But making sure that we've got the right folks is actually going to be pretty important. Now, how on earth am I going to do a patient survey when somebody has dementia or perhaps delirious, and that's why they have a sitter? These are the questions that I hope to be able to ask the patients that I'm working with, and likely I'll have a chance to ask these questions maybe towards the end of the time that they actually need to have a sitter, just to kind of ask them about kind of their experience and what was helpful, what was not helpful. So this is something I'm still kind of working through and thinking about. So what is the reality? This is an issue. We can certainly reduce sitter use with well thought out processes with the evidence that backs it up. I've got data. I've got information, so we'll use that. Certainly want to allow the hospital to put almost $1 million somewhere else in the other endeavors that they've got going. Of course, it's always going to be safety first. That is, certainly one of the biggest important pieces. But I hope that the staff at the hospital will participate in the trainings, participate in the education, certainly staff huddles. But mostly, it's we want to make sure that we're being fiscally responsible with the evidence-based information to provide safe and responsible care. So I love this website, Agency for Health Care Research and Quality. So this is just a snapshot of one of the articles that I've been reviewing. Their goal is to make healthcare safer, keep patients safe, while making sure quality is up there. And they have data. So definitely look forward to kind of tracking that information. Slideshow.
Thank you.
And did I stop? Oh, I stopped screen sharing. Okay, great.
Thank you. Great. Okay, Bethany.
Okay, so let me see. I need to open my whole screen, right? If it's PowerPoint?
Yeah, if it's PowerPoint, you just share your whole screen. Mm-hmm.
That. How do I share the whole screen?
So when you go to the green box on the top left, hover your mouse on the top left corner. When you hover your mouse there, a green screen with a white arrow in it should show up.
Okay.
You see that?
Yeah.
And then click on that, and then it'll ask you, do you want to share your whole screen or just an application?
Well, let's see. Share. Oh my goodness.
Yeah, isn't that weird?
There's a gang of them.
Yeah.
Do you see all of those?
When you go to your application, that should go away.
Okay. Yeah, that's kind of. All right. Let me see where Sorry. Okay. Can you see that?
Yeah, it looks
Okay,
great.
perfect.
And then just share the whole screen or make
Okay.
it full screen or whatever.
So sorry. And let me see here. Where is that at for the whole share? It's usually down here on the bottom, isn't it?
I see
You
at
max
the
it out.
top. At the top, let's see, view. Oh, slideshow. You could go to slideshow at the top.
Oh, gotcha.
Yeah, and then just say play from
There we
current
go.
slide.
Thank you. Sorry, I'm
no,
old. Okay, so my project is a little bit different. I'm very inspired by everybody else's, but I'm doing like a process improvement project, and it's decreasing missed appointments in the outpatient psychiatric office. This is Transition Center. It's in Tempe, Arizona. It's outpatient. We all work at Aurora Behavioral Health in the morning and then see patients here in the afternoon. So my goal is to join me in decreasing missed appointments at Transition Center. This is me. I've worked in healthcare for nearly 35 years and have always been drawn to working with the vulnerable populations. While employed at the acute care psychiatric hospital, I witnessed how empowering it is to know that someone truly cares for your well-being. I seek to provide holistic care while striving to educate and improve the safety of patients with mental illness and or substance abuse. So the core value for our providers and our staff is compassion. And it's a feeling of deep sorrow for another who's stricken by misfortune, accompanied by a strong desire to alleviate the suffering. We treat substance abuse. We have a lot of homeless and SMI population, especially Tempe, Arizona. We treat child and adolescents and, of course, SMI patients. So intro to the problem, Transition Center has 22% missed appointment rate compared to a median of 17% for similar psychiatric clinics in the area. And patients who are not attending appointments or receiving their medication refills may be experiencing deterioration of mental health and are twice as likely to be hospitalized than those who are compliant with their medications. So I did a chart audit on 20 of my own patients, and I was looking for a correlation between no-call, no-show appointments and their diagnosis, if they'd been previously hospitalized, if they had a balance due, the length of time they were in our practice, if they were cash versus insurance, able to reach them for the reminder call, and let's see, evaluated like our service recovery. So of 20 patients, we had 26 no-call, no-show appointments, and granted, one patient accounted for 6. I found that although we have a policy for fees being charged, we did not charge in one single case. The length of time between the appointment being scheduled and the day of the appointment was about 2 to 4 weeks. And the majority of the diagnosis were substance abuse and major depressive, with the majority being previously hospitalized. I thought that a balance due would play a part in it, but it really did not in there. So here's my team survey questions. I had originally posted the whole survey, but then I went back and before I submitted it and looked at the template, and it had like the top 5. So this is what I did. So we have 1 MD, a PA, 2 psych mental health nurse practitioners, 4 MAs, and then we have a front office. So I was asking about their comfort level with the goals and how comfortable they are making suggestions for QI. And when do you think team huddles should be attended? Because we're all independent contractors except for the primary psychiatrist. So our schedules are varying. How important do you feel communication is? And does staff understand their roles and responsibilities? And I have received some information back. I passed out the surveys and they're trickling back in. And then I've also, yesterday and the day before, or Thursday and Monday, I had some of my patients complete the survey, but I have not been able to evaluate them yet. And my thing is, how difficult or easy is it to schedule an appointment with our office? Because we're a smaller office, it often goes to voicemail, or they have to press 1 or what have you, and they don't always get a live person. So they're going to go on to the next provider on the list. And then, did you receive an email or phone call prior to the appointment? Was a reminder within an appropriate time frame? Would you be interested in using a patient portal if available? And if you have missed an appointment, was it due to work, scheduling, financial, transportation, or mental health itself? So in conclusion, I'd like to reduce the number of missed appointments to 10% or less in the next 6 months. Please help me to meet our clients' needs and remove barriers to care. And let's make their appointments easy to schedule, simple to reschedule if needed, provide reminders in their preferred manner, and activate service recovery for missed appointments. Scholarly Curiosity is NAMI, National Alliance on Mental Illness, and it's the nation's largest grassroots mental health organization dedicated to building better lives for millions of Americans with mental illness. Has a lot of good information for patients as well as staff and lay people. So let me see here. Let me try and come back now to where I was with you. Okay, let's see. Now I just have to find you again.
Yeah. And then you got to click the stop sharing button on the screen once you come back to us.
Okay, stop sharing. Is that up above?
I think it's on the, I don't know. I think it's on the top
sharing. I
middle.
see it. Sorry.
Okay.
Yeah, sorry.
Where was it? Just so I know.
In the middle, the little blue button
Okay,
that I wasn't
all right,
expecting.
cool.
Okay.
Perfect.
Thank
Okay.
you.
All right. Awesome. Great start, everyone. That's like, I'm so excited. You guys are totally on track. It's great. So, okay.
Yeah.
So relax, relax. So some common things that I saw, which were the same in the last group, because you have to remember that these lessons are formative. And what that means is, or these assignments are formative. And you know, what that means to us is that you're learning by doing the assignment. So we don't expect you to get things perfect right away. And that's why first versions of assignments are worth a lot less points than the final versions, because we know you might miss a lot of things your first time around, and we expect you to learn, and then by the end you get it. So the last assignment's worth more. So one of the things is, with your chart audits, now that you have a better idea of your gaps and of your topic, you want to, if you don't have 15 project specific criteria, you want to go back and do a chart audit with those. So for example, let's say your first chart audit was really general and you only looked for maybe, like, let's say someone's doing depression screening and they looked only for like, how often was depression screened? Was it done annually? Like, is everybody up to date? Did we refer them if appropriate, or was treatment offered? Like, maybe those are only 4 things that they were checking, right? But then when they identify the gaps, they're like, oh, now I'm going to dive deeper and ask even more questions. Like, how many people screen positive for mild depression or moderate or severe? Like, those are 3 different questions, right? And so, like, you're going to go back and do a chart audit if you need to on 15 items that are project specific. You can do more, but at least 15 items that are specific to your project, okay? So, you know, for Bethany, like if you're doing the missed appointments, like, you know, you're going to have to think more about, like, okay, like, is it a motivational thing? Like, how often is this happening? Well, are there any common variables between people who miss appointments? Is there a common diagnosis or a common socioeconomic class or something, right?
Mhm.
So you just got to like dive deeper into that. Now for your team and patient surveys, similar now, a little different, but you started off with these fairly general questions, right? Like, does my team feel safe to give feedback in type of questions? Now you want to ask even more specific questions about your project. So if you don't have, you know, at least 5 questions that are project specific, you want to do that, okay? Meaning you're not just asking stuff you have no control over. Like, it's kind of a useless question to ask, like, is parking hard for you? Unless you're doing like a missed appointment thing like Bethany, right? Then that might matter. Maybe they're like, I'm not going to go because parking is so annoying. But for everybody else, like, that might not be as important. So like, don't, like, toss that out. Like, you don't need that because there's nothing you can do about it. So toss the ones that were not helpful. Toss the ones that you scored perfectly on, because you're not going to address those. The only exception to that, I would say, and there probably are more, but one that comes to mind is satisfaction, team satisfaction, patient satisfaction. That you might want to keep in there, because even though, let's say it's high, you want to make sure it doesn't drop in your project. Okay. So you want to make sure that that's like a balancing measure. But everything else that's scoring really high and like you can't do anything about it, you don't think it's going to change, just toss it. Put in more useful questions for you that'll make your project evolve more effectively. So ask questions to your team like, oh, so you can ask questions like, I feel comfortable talking about trauma with patients, even though that's not the subject of their visit or something, right? Like, how I feel confident. Let me see here. What's like another example? Like, I feel confident on community resources to give to patients when they're having breastfeeding issues, right? So there's lots of questions you can ask that don't necessarily come to mind like right away, but you can start saying, what are specific things my team need to know to be good at helping me with this? Like maybe for Lee, it could be something like, I feel I can reach out to colleagues if I need support with this project, right? Something like that. Because even though you're not meeting as a team all the time, like you'll need to have a few meetings where they're all together, but not all the time. But you know, what questions can you ask them so that you can make sure they do a good job? So with breastfeeding, I feel comfortable talking about this. I feel comfortable how to discuss it with a woman who's very clear that she doesn't want to breastfeed, right? I know community resources. So you're starting to think more about like, what does my team need to know or feel to make my project a success? So by feeling, I mean those questions like, I feel confident doing XYZ. I feel comfortable doing XYZ, okay? And same thing for patients. You're going to be asking more of those questions about, you know, I feel comfortable with the community. I know at least 3 resources for helping me if I have breastfeeding problems, you know, on a scale of 1 to 5. So try not to ask yes or no questions, because when you're measuring them, it's a lot harder to gauge the subtle improvements. Because then you might not see an improvement if all their only option is yes. Whereas if you're asking, how comfortable are you? Or I know at least 3 resources, that's kind of a yes or no question, but it can still be phrased as like a Likert scale, like 1, you know, a little bit, and 1, like strongly agree or something. Because maybe if they only know 2, they'll pick like a 3 instead of a 5 on the Likert scale. So the Likert scales are nice because they can gauge more subtle changes, and your data will be more detailed as a result. You also want to, let me see my notes here with the Likert. Oh, you want to have all your questions phrased in the same direction. So in a lot of psychology assessments, they try to mix things up so that people don't get used to circling 5, 5, 5, 5, 5. You don't want to do that on this project, okay? Because it'll mess up your, like, you don't want to mess with that complicated data. Basically, everything needs to be scored the same way. I mean, I suppose you could mix it up, but your data analysis is going to be a pain in the butt unless you're really good at Excel and knowing how to like flip results and score them differently. So for the purposes of this study, since it's not in a psychological assessment per se, or project, not study, you're going to just do everything. 0 is bad, 5 is good. Okay, you're not gonna have tricky things where all of a sudden it's flipped and 0 is good and 5 is bad. So just always have it be the same direction so that your data collection and analysis is easier. For the backgrounds, a lot of you had financial information, some of you did not. When you give your background, you want to make sure you're including solid numbers there on the regional level and on the national level. So like on the national level, you know, the rate of depression is this, this, and this. And in our community, we actually have a higher rate of 20%. Like Alaska's depression rate is like 25% or something. And our suicide rate is really high, like compared to the national average. So I'd give the national average, and then I'd give my like local numbers. And then I'd say, hey, like these are the financial, these are the financial gains or losses related to this project. And so that's really important, because in the end, that's what motivates people. Like fortunately or unfortunately, like you need to tell them this project's important because it will save tons of money, or it will prevent money from being lost, or whatever it is. So financials have to be in there. So find those if you don't have them already. If you haven't had your library session yet, you can ask questions there for that. But if otherwise, you can always reach out to the librarians, and they're really good at helping you find the resources to get those statistics, okay? Let me see here. I saw a couple questions about like the patient questionnaire was like, I received handouts. That has historically led to problems with projects, because the patients, you know, yeah, I received them, but it doesn't really tell you if they read them or used them. So remember that this is all about utilization. So it's not just, did everybody get the screening tool? It's, did they fill it out? It's not just, did everybody have a shared decision aid to talk to the patients about, was it used? So try to switch to like utilization. Like, I read the I read the handouts, right? And you may have to change that later, but it's okay. Oh, let me see. Could you hold on 1 second? I'm having like a little bit of sound thing. Is that okay? Can you hear me?
Yeah.
Okay.
Yeah.
Yeah, it was being kind of weird. Okay. And so, what else here? I think those are the main things I saw that were common, amongst all of them, or common but between the groups. The other thing is with time, you just want to make sure that you practice your presentations so that you're on the mark. Like for this one, we're a little more flexible, but all the future ones, like if you go over, we don't even count that information. So it's not that you just get some points off because you went over, but like if you talked about a whole slide when you went over, like that, it's as if that slide didn't happen. Okay. So just be sure to practice and time it and everything. And then let me see here. Yeah. So that's it for my feedback. I thought it was awesome. Like these are really common things. This is part of the learning process. I expected to have to say a lot of these things. So what questions do you have for me? That's okay. The other group didn't have that many either for whatever reason. So, okay. Let me see here. So in terms of the different projects, let's just touch base with that. As you've probably seen, there's like SBIRT projects, which involve screening. Okay. So if you are having a problem screening, your project is going to be a SBIRT project because you're going to try to improve the number of screenings that you're doing. You're going to have an increase in number of positives, and then you're going to apply an intervention. Like Lee's is more of a screening one, right? Like we're going to make sure we're assessing for that. Then we're going to provide a brief intervention and then a longer term follow-up. With those, just remember the intervention itself for screening positive doesn't have to be epic. It can be 2 minutes or less. In fact, that's the definition of a brief intervention in an SBIRT model. Screening, S, brief intervention, BI, and then referral and treatment. It's not just referral, though. You have to remember that in these DNP projects, it's not just, oh, I referred them to trauma specialists or something. It's more extended follow-up, like, did they make the appointment? Did they attend the appointment? Not just did you refer?
Yeah.
Then if you are good at screening your topic, or it doesn't even involve screening, then it might be a right care project, in which case you're just trying to improve what's being done already, or something that's supposed to be getting done isn't getting done. That's the right care project, where you're like, no, we're actually really good at screening for depression. We just kind of suck at doing something once we see it. Another common thing like that is obesity. Like everybody has the BMI in the chart, but no one looks at it and no one does anything about it, right? So that's an example of the right care. And then you have the process flow. It's so cool. We have an example of that in this group with Bethany, right? Like really wanting to change the flow of patients through a clinic. ERs also like this type of project because they want to increase or decrease the length of stay. All right. One very important thing to keep in mind for everyone is you have to have at least 6 patients a week moving through the entirety of your project. So if you're screening and you're like, this is awesome, we've increased screening to 80%, from 20 to 80%, your project still can't move forward if only 2 people are screening positive. And then they don't get to move through the rest of your project, like the brief intervention or the follow-up. So you need at least 6 patients that are going to have contact with your BC and D ramps. Okay? Does that make sense? Or let me ask this, who does that not make sense for? Okay. Yeah? Ask me, Sandra. What are you thinking?
Just a lot of lingo right now. Then.
Yeah. So you're breastfeeding. You're doing breastfeeding. You're improving those rates. So you need at least 6 people.
You're talking about for the. Is this part of the planning right now that you're talking about, or is this part of?
Yeah. So this is thinking big picture, like taking a step back from planning and just making sure that your project's even going to work.
Okay.
Because there are students who will tell us that they have enough volume, and then they get all the way to implementation, and they're like, oh, it's so weird. Only 1 or 2 people are screening positive for depression, right? And then, sorry, like that project can't happen. You're going to have to pick a different topic, and you're going to have to drop the course, and then you're going to have to pick a different topic and then take implementation again. Does that make sense?
Yes.
Yeah. So just make sure that whatever project you're picturing, that you have 6 patients a week that are moving through it. All of you seem like you'll be fine. Okay. So, but just there may be things that I don't know about your particular site. So just keep that in mind.
So I have a quick question.
Yeah, go ahead.
So you mentioned moving through. So one of the things that's going to be really important in the project that I'm working on is actually screening. Nurses will be screening folks to see if they're appropriate to have a sitter, for example. And some people may use the screening. So we're developing a screening tool. So that's one of the creative ideas that we're coming with. So we're developing a screening. You're muted.
That has all of the criteria for appropriate criteria, so they can follow like an algorithm and see more clearly.
That's correct. That's correct. Because right now in our policy, it states step 1, step 2, step 3, step 4. And so nobody follows those steps. So the reality is that when they do that screen, if they're not appropriate, it stops right there. But I imagine that we would have anywhere between 10 to 20 patients a week that will potentially be screened, but it doesn't automatically mean that they're going to get a sitter. So the screening process essentially means that it's working. I just want to make sure that this falls in line.
Yeah. So yours might actually. Like there's a couple of other areas I see that your project needs, which is also like appropriate discontinuation of sitters when they're no longer needed.
Yes.
So those could be like 2 care ramps almost.
Right.
Like, are you screening appropriately and are you discontinuing appropriately?
Right. And the idea is that every person that anticipates a sitter will be screened, and then every person that has a sitter will be screened every single shift, so that they can put those things in place to appropriately discontinue the sitter.
Mm-hmm. Is there anything that happens when so someone screens positive for needing a sitter, then they get the sitter. Is there any gap in that whole period other than people having sitters for too long?
Well, I mean, the other piece is that they get certainly receive an evaluation by the behavioral health team to provide recommendations on interventions to either help with their mentation, help with the delirium, help teach the staff how to manage somebody with dementia. There's some stuff there that we can do.
Yeah, so I think that might be a more robust project where you're doing a screening project. So you screen properly.
Right.
And then for the people that screen positive and the people that currently have sitters, you're doing the brief intervention thing. And then you're doing your D ramp is a right care ramp. And you're making sure that they got an evaluation about their meds, that they got this and that. So everybody's getting that.
Yep.
And so even though maybe you only get 2 people screening positive that week for needing a sitter, then there's at least 4 people who already have sitters, right? Or
Right.
something like that. So you just
Right.
need to make sure that any given time there's 6 people in some process of needing medication evaluation, psych evaluation, or something like that. Okay,
Okay.
to either start or discontinue. And then
Yeah.
one of your right care elements in the DRAMP, most people do a case management log where they're tracking all these things. One of those elements will be timely discontinuation.
Right.
And did that happen or not? Right.
Right.
And you'll score that. We'll go into that later in the course.
Okay.
So yeah, does that
Okay.
help?
Yes, that helps.
Okay. Anybody else? Okay, so we talked about the different project types. We talked about the surveys and everything. Okay, so what about the next step in the gap analysis assignment? What questions do you have about that, or have you even looked that far? I can pull it up here.
Yeah.
Let me see. I'm just logging in. Okay, where are we? We're at spring. Okay, and then I'm pulling this up, assignments. Okay, and then, okay, so the next one is from gap to measures, right? And so with that one, this is where you're going to be the gap to measures PowerPoint template. Okay, so with this one, you're doing your measures worksheet, and I believe you're also going to be sharing your tools, okay? So I just want to let you know that the measures worksheet can be really confusing for people. The language in it can be kind of stressful, but we made some really good videos that I think are much better from past courses that I think it should clarify some things. If you're having problems understanding the measurement worksheet, let me know, okay? But I think that the videos are pretty darn good. Basically, the measurement worksheet is, just look at it more like a simple table. It shouldn't have a bunch of words like, oh, so for the numerator, I'm going to make it this and the denominator this. Like, we're just saying, how are you going to actually make this mathematical? Just how are you going to represent these concepts mathematically? How are you going to represent improved screening mathematically? Percent of people screening positive, right? So that's all you put, percent screening positive. And so there are some examples in those videos. Watch the videos. Super important, okay? And the tools. When you're going to look at the different tools you're going to use, there's a lot of tool kits out there. So there's like, trauma kits and breastfeeding toolkits, and those are really big. But what we're asking for in this assignment is not the toolkit. What is the actual tool you're going to use for that ramp? So if you are wanting to do a shared decision aid for your patients, like you can do, a breastfeeding algorithm, right? That's a shared decision aid to help them decide if breastfeeding's for them, what might be the biggest obstacles they might have, yada, yada. So that's what we want to see. Not the like, oh, this company has a great breastfeeding toolkit. We want to see the actual tool you're going to use with your patients. And then if you're going to do team huddles or team meetings as your team thing, what's the tool you're using to make sure that that's going the way it is? Is it a huddle checklist to make sure you cover all these points during each meeting? If you're doing like in Bradley's case, if you're screening for this appropriate sitter use, like we want to see what that form looks like, not like here's the guidelines, right? So that's what we mean, okay? So the actual tool, a simple way to think of it is it's a piece of paper. So like something that you would be able to print out and show me, that's the tool, okay? Not a link to a website, not a big like packet of stuff, like what's the actual tool? And every ramp will have a tool, okay? People get really confused about the team ramp, and it's really like, we're just saying, how are you going to make sure that your meetings and your interactions with your team are effective, other than the evaluation and your surveys? Like, what are you going to cover at each meeting, for example? Like, oh, we're going to make sure we're going to give an update on the project. We're going to have a feedback section. We're going to have any flow concerns or any other concerns. We're going to have a kudos to like help people feel better, like read some positive patient feedback at each meeting. So like that kind of stuff. Okay. And that'll make more sense as you dive into that assignment. All right. I mean, that's all I got. If you guys don't have any more questions, but I'm here. So remember, in my email signature, you will see this is how to make an appointment thing blurb at the bottom. It also reminds you that if you don't see anything in the calendar, to send me 3 dates and times that work for you. A lot of students forget that, and they're like, oh, you had nothing available for 2 weeks. And I'm like, you were supposed to email me 3 dates and times. We always make something work. We're here for you. We want to help you succeed. Okay. So, oh, and this is recorded. So you'll have a general memory of what I talked about, but you probably won't remember everything I said. So I'll give you the link to this after this call, and then you'll be able to play it. And if you have questions, first think, did Dr. Verzoni potentially talk about that on that call? I'm going to like watch that real quick and just make sure, because if I did cover it, I'm going to say, go watch it. Okay. All right. All right. Well, thank you, everyone. It was super fun meeting you. I'm excited to be with you for the next few terms. It's going to be awesome. We're going to have a great time. You guys have great projects. You're definitely earning your DNP at Frontier. I feel really proud about that. It's not just like a give me DNP program. There's rigor and it's hard, and you'll feel really good about it when you graduate. You'll feel like I really earned it, and there's a reason people call me doctor now, and it's really cool. Okay? Right on. All right. Have a great night.
Thank you. You too.
You too.
Thank you.
Bye,
Bye.
everybody.
Bye.
Bye.